Welcome back, everybody. So as we mentioned earlier, this next session is going to be, 15-minute individual talks by, leaders in the field from across the world. And they're going to just share their experiences and what they've learned in their journey with limb reconstruction. And it's a very free-for-all session. So, everybody's going to sort of do it in a different format, but that's awesome. So our first speaker, it's my great pleasure to welcome Dr. Scott Nelson, my dear friend, who's I think in Haiti right now, but is based out of Loma Linda in California, but he spends a good portion of his time in Haiti. So Scott, if you don't mind, just share screen and you can take it away. Thanks.
Yes, I'm going to start just before I share screen by introducing you to a couple of people that are here with me. And good morning, everybody from Port-au-Prince. I'm Scott Nelson, and thank you, Senji, for putting together a great conference and allowing me to participate in this learning experience. I'd first like to introduce my fellow Dr. Isaac Archulus. He's from the northern part of Haiti in Port-au-Prince and just finished his residency here at the state hospital last year and is doing a 6-month fellowship with us at Hôpital Adventiste before he goes back and starts his practice in the northern part of Haiti. And this is my other fellow, Connor Spady, who's a graduate of Loma Linda University and has been here this past year, almost done with his fellowship in global orthopedics. And he incidentally will be starting a trauma fellowship at UCSF next month. So it's a pleasure for us all to be with you. And I'm going to start by sharing screen here. And there we go. And we'll put in slideshow mode. So this is our hospital, the Adventist Hospital, just outside of Port-au-Prince. Hôpital Adventiste Haiti is truly an island of hope and healing amongst a sea of despair and suffering. Just this week, we've had a lot of additional political strife around us with gunfire every day, and we're actually having a little bit of peace at our hospital today because the patients can't get here due to all of the unrest that's surrounding us. We have a large portion of our patients that have limb deformity problems, bone deficits, and most of our work focuses in trauma and pediatrics. My own history is working in the Cure Hospital in the Dominican Republic, where my wife and our 2 young boys and I moved in 2005. And I was the medical director there until 2010, when we went back to Loma Linda, and I remained faculty of the university. And when our boys got old enough, they moved off to college definitively, and my wife and I moved back here to Port-au-Prince, Haiti in 2018. We've been here for the last 5 years. Lessons learned will be in these following categories, and I'd like to first talk about the lesson that I've learned about the importance of leadership. And as surgeons, we can't get good results with the operations that we do on our own, and we need to attribute our successes to the teams that we work with. And by default, we are leaders, but very little of our formal education focuses on leadership techniques, and I've taken the initiative myself to try to fine-tune my leadership skills, my interpersonal skills. I wanted to share these 2 references with you that I found to be particularly helpful. The one on the left is an old classic, originally published in the 1930s, and I call this uncommon sense. It's actually not a term that I coined myself, but these are common sense items that help you in all walks of life that we uncommonly really think about in our conscious mind. And From Good to Great is another well-known book by Jim Collins, who looked at companies that rose to greatness, and it's not only succeeded for a short period of time, but over long periods of time were successful. And they looked at the characteristics of the leaders of these companies, and they found that these people in general were not egocentric, domineering, commander type of personalities, but they were rather humble people who worked hard, and they attributed all of their successes to the team, to those around them. And when there was failure, they took the blame for that. They took the responsibility for that. As the medical director of our hospital here in Haiti with 240 employees, number of educational programs, these learning experiences have become particularly important for me. The second area is knowing your patients. We see these two guys here. They came from different parts of the country, actually both from outlying islands with opposite deformities. Unfortunately, the guy in the red shirt had been to our hospital for 2 previous operations. You can only imagine what happened. He originally came with genu varum. We performed some guided growth due to all of the challenges in Haiti, political strife, pandemic, fuel shortages, protests, lack of transportation, lack of resources. He didn't come back on time. We had a talk with him. He promised, he understood the importance of this. So he took his guided growth plates off of the lateral side and put them on the medial side. But yet again, unprecedented amounts of strife have kept spiraling down here in this country, making it difficult, even with people who have put forth the best efforts to come back. And he unfortunately came back with this deformity. His friend here was here for the first time. And with this given history, learning our lesson, we treated them both with acute corrections. And they met each other for the first time in the same hospital room and were great support to each other for recuperating from this operation. This is another girl, 17 years old, that lives very close to us. Showed up at our hospital with a congenital short femur. And I was wishing I had all the resources of the modern world. And in reflecting on that, I decided that I needed to do everything possible for her, and incidentally ended up treating her acetabular dysplasia with a PAO and getting a donation for a magnetic lengthening nail. And her success here is really not attributed only to my effort, but those of our entire team, our physical therapy team, and the effort that she put forth to do this 7.5 centimeter lengthening. This is a 7-year-old girl. She was one of the cases I treated in the Dominican Republic, but she's a Haitian girl and had severe Blount's disease with medial growth arrest. And at this age, no matter what we do to correct the deformity, recurrence is a significant concern. And so I did bilateral hemiplateau elevation osteotomies with complete epiphysiodesis of the proximal tibia, placing hexapod frames on her to provide some lengthening to compensate for the growth arrest at this young age. But what I didn't realize is that her mother was illiterate and her father was blind. And in spite of them seeming to understand how to do the strut adjustments, she came back for her postoperative visit and nothing was done correctly. And I had to go to the extra effort of riding my motorcycle across the city through some barrios that I wouldn't normally have dared to go through, and visited the family and taught the neighbor how to do the strut adjustments. And we were ultimately able to get success. So I think the lesson learned here is that nothing is impossible, but sometimes it takes a lot of extra effort. Shared decision-making is a popular topic now in talking to our patients about what their best treatment is and letting them participate in it. And the paradigm for this is a little bit different in the environment in which I work. Some of the patients obviously can't really conceive the implications of rotation plasty or other complex procedures that we might be proposing. And in this case, the girl had a predicted 32 centimeter limb length discrepancy, not leaving us with a lot of options. And after explaining the procedure extensively to the mother, we did decide to proceed with rotation plasty. It was a successful surgical result. We have a wonderful prosthetics lab here and fitted her with a prosthesis, helped her with physical therapy. And at this point, unfortunately, I've heard that she's gone back to where she lives out on the adjacent island, and she doesn't wear her prosthesis, and now she has a foot that's rotated backwards. So maybe I need to back up to my last lesson learned and make a visit out there and find out the exact limitations to having success on this case. So that's a lesson in process, of which many of my lessons are. I couldn't help but share a few surgical tips and tricks in a lessons learned talk. And this is Clifford. He has severe osteogenesis imperfecta. And in spite of this 120-degree plus tibial deformity, he's still able to walk. And in this case, we performed acute correction with Sofield nailing using rush rods. And with these severe deformities, I've learned to use a lot of shortening. I think the lesson learned here is to not be afraid to shorten when you're doing acute corrections of deformities. And you also need to be generous with your fasciotomies, prophylactic fasciotomies, and nerve releases if they are at all a concern in these types of cases. And instead of putting him in long leg casts, which you might have expected in the resource limited environment, we place external fixators, which makes it much easier to manage the wounds. And actually at our hospital, it's cheaper for us to use an external fixator, reuse an external fixator like this, I should say, than it is to put on a cast. Being organized is extremely important in this resource limited environment. We need to know what we have and have it ready when we need it. And this has motivated me to almost be hyper organized in making sure that every resource that I do have is ready at the right time. And Sanjeev mentioned earlier about my trip to India. I had ordered some implants from these guys a few years ago, and it was a good experience. He recommended them to me. It cost me more than twice as much to ship the implants to Haiti as it did for me to buy a ticket and go visit them for a few days. And developing that personal relationship was a great experience. It helped us to refill our implant stock in a cost-effective manner. And they bought me some great Indian food while I was there. And it's really been a significant help to our implant stock. I love measurement tools. We use these all the time in the operating room. The more ways that you can measure things, the more accurate you can be. Sterile goniometer, sterile inclinometer. We use our C-arm measuring tools. The iPhone, anybody with a smartphone, an iPhone has some type of angle measuring device, which is really helpful. And Dror Paley gave me this X-ray grid that I keep on my radiolucent table, which helps us to define a lower extremity alignment. And this is my X-ray table. Sanjeev already showed this, and it actually goes up and down. We have to screw out the feet, and we can move it up or down about 10 inches and fits nicely with our C-arm. And it's really 95% as good as most of the much more expensive tables that I've used in the United States. This costs us about $200 to make. And lastly, when working in an environment that's challenging, it's important to be positive. Any of you that have heard news out of Haiti, I am almost certain that it hasn't been positive. But I can tell you for sure that's not the entire story. There are many great things about working here, and the people are wonderful. The kids we take care of are wonderful. Their ability to recover from operations, their resilience is something that I don't think I've ever experienced in the United States. We have a very low threshold for taking cases back to the operating room if we need to. There's no insurance approval process here. It's simple to give really timely treatment to these patients. This is a case here that was just a burn contracture. The child couldn't wear shoes to school, and we released the burn contracture, put some skin graft, and decided to just stabilize this with a $20,000 hexapod frame, which I'm sure would never have been justified had I been doing this case at Loma Linda. So it's a little bit of a paradox. These patients don't have any narcotics after surgery. We don't have access to narcotics at our hospital. And I think about the postoperative pain that patients have is being similar to a bucket of water. And if you dump it out quickly the first day after surgery, our patients recover really rapidly and they almost have no pain after that first 24 hours. But if you prolong it and pour the water out slowly with lots of narcotics along the way, it seems like the patients end up suffering for much longer. We don't want to not be empathetic, but there are some advantages to getting over the pain early on, and especially when you're in a hospital that doesn't have good crash carts, doesn't have personnel that can perform resuscitations quite as effectively as in some other places. Thank you very much. And I think the most positive thing for all of us is to be able to have the privilege of performing life-changing operations for these wonderful patients that we get to serve around the world.